Hi, everyone. Thank you all for joining us today for our GlobalSkin and ILDS webinar, Creating the Rare Disease Movement, the Power of the Patient Community. So before we begin, my name is Nicole Sudiaco, and I am the Member Services Manager at GlobalSkin and will be moderating today's webinar. For those of you who may not have heard about the International Alliance of Dermatology Patient Organizations before, also known as GlobalSkin, we are a unique global alliance committed to improving the lives of patients worldwide. We nurture relationships with patient organizations, partners, and all involved in healthcare, building dialogue with decision makers around the globe to promote patient-centric healthcare. We represent nearly 60 countries, 65 disease areas, and we have nearly 180 member organizations. This webinar is to celebrate Rare Disease Day 2021 happening on February 28th. And it's great to see so many familiar faces, as well as many, many new faces. We have a special audience of patient leaders, doctors, and medical professionals joining us today from all around the world. We'll be learning from our world-renowned guest speaker, Dr. Ségolène Aymé, who will be speaking about the power of patients and patient organizations with regards to the rare disease community. She will also be speaking about her important work with Orphanet and Expert centers. And without any further delay, I will hand over the microphone to our interim CEO, Jennifer Austin, who will introduce the ILDS.
Thank you, Nicole, and thank you everyone for being here today, and especially Dr. Aymé. We're honored to have her participate in this important webinar. So for those of you who are familiar with our organization, you're likely aware that more than half of our member organizations represent rare dermatological diseases. So this is a really important webinar for us today because we know that those patients are very underserved and have needs that are not being met. So we can work all together in trying to address those issues globally. I'm pleased to welcome our co-host today, the ILDS, and I'm going to, in a moment, do a quick introduction here to pass the microphone, but the International League of Dermatological Societies is one of GlobalSkin's really important partners. We represent the patients globally, and they represent the dermatologists globally. And the ILDS was actually a key part of the founding of our organization because our organization was founded at the World Congress of Dermatology in 2015. And that is their major conference, which takes place every 3 years, 4 years. So I think it's 3 years, or is it like the Olympics, 4 years? And so Luca Borodori was to do an introduction of Dr. Aymé, but I don't think he's managed to make it yet. He's likely with a patient, but I'm really pleased that Somana Akadu is here, who is the partnerships manager for the ILDS. We're very proud with our involvement with the ILDS formally. We've recently joined the Patient Association's working group of the ILDS, of which Professor Luca Borodori is the chair. The ILDS has also involved us now for the first time having patient voice in the creation of their program for the World Congress of Dermatology, which is taking place in
2023.
Yes, okay. So without further ado, I'll introduce Somana Akadu, and he can give us a bit more information about the ILDS. So thanks again for co-hosting this with us, Somana. We're really honored.
Good afternoon from UK. I am Somana, and I'm the partnerships manager from the ILDS, International League of Dermatological Societies. And welcome to the IDPO members and the ILDS members. I know it is a joint collaboration between the two of us. So amazingly, it's very well attended today. So welcome to both members. Just briefly to give you an overview of the ILDS, and then I can introduce you to Dr. Segolene Aymé as well. We are pleased to have her on board for this webinar, and I'm sure that's what you're looking forward to. So I'm not going to waste too much time to talk about ILDS. Oh, we've got Professor Luca here.
But I'm really proud that we were able to organize this webinar together with the International Association of Dermatological Patients Association in GlobalSkin for these important topics in the month dedicated to rare disease, and by having a my preferred, or probably the speaker that everybody would like to have to speak about such a theme like rare disease. And I'm very glad on behalf of the International League of Dermatological Societies as well as GlobalSkin to have Professor Ségolène Aymé, who is an outstanding person, and I will introduce you in detail in a few slides. But thank you very much, Segolene, Professor Aymé, to be here. I'm very happy to see you after probably 10 years or 9 years. Please, can you show the next slide, Samona? So just the ILDS is there to try, is an organization, the umbrella organization of all dermatological societies on the world. We try to, our vision is to provide, attain the best possible skin health for all people around the world. And our mission is, of course, to promote, to make advocacy for awareness, cooperation, communication within the global dermatology community in order to promote better care of patients affected by skin diseases by interacting with all possible stakeholders. So we have a number of strategic areas, and one of our main action point is representation and engagement. And when we speak about engagement, is also engagement with patients in patients' organization in order to, with the various stakeholders, to provide the best access to medical care and to allow patients to, and in this regard, with regard to patients engagement, our International League of Dermatological Society has a patients working group which should take care of this interaction with patients, and to, in order to emphasize how important are patients perspective, patients need in the entire course of the evaluation of patients' need in respecting patients' visions and in integrating patients' will in their treatment, and also to protect their right. So. And we have as a working group, or patients organization working group, a privileged interaction and association, so interaction and collaboration with GlobalSkin and the International Alliance of the Dermatological Patients Organization, which co-host this webinar. And now I'm very happy for the day for rare disease in February to have Professor Segolene Aymé, who will discuss and present us her view, her perspective, her expertise in all efforts she had in order to create a movement to promote the issues, all matters related to rare diseases and the power of the patient community. And here you see on this slide a number of functions that Professor Aymé has had in the past decades. So she's the person who in Europe really was the person who first realized how important to fight and to promote a reference center for people affected by rare disease. So she founded Orphanet, which is the European database on rare disease. She also contributed and established a journal which is now one of the reference, Orphanet Journal of Rare Disease. She can you imagine, at the European level, she has been for years chairman of the European Commission Task Force on Rare Disease, also for the European Union Committee of Experts on Rare Disease. She has been also an expert for the World Health Organization on the topic of rare disease, and she has been a manager and involved in the executive office of the International Rare Disease Research Consortium. So you can imagine we have here with the person who can really tell you from the beginning all how to fight, how to try to move things forwards in order to take care of patients with rare disease at all levels. So, Professor Aymé, Ségolène, thank you very much. Merci beaucoup que vous avez pris le temps. I'm very, very happy and proud to have you.
So I've been asked to share with you my views on where we stand currently in the field of rare diseases and what you could do better to serve the patients at the end. So I'm going to speak very freely because I'm no longer, let's say, responsible for any active committee in the field or have no responsibility anymore. So I can just think and share my thoughts based on my experience. So at the end, we will be able to discuss these views, and excuse me if it's not exactly what you expect, or if you think that have a too personal analysis of the situation, but it's really what I think would be of interest and for you. We should go back to see what we have achieved to discuss what we could do in the future. So in the past 20 years, I can say that the patient organizations have played a major role. First, because they were able to get organized, usually at the disease level first, and usually at national level, but also the patient organization were mature enough as to have umbrella organization at national level for all rare diseases. And this was extremely instrumental in pushing for public policy at national level, at least in Europe, because I know that in the US, the situation was quite different, and the patient organization mainly lobbied to have more research done in their area. But in Europe, you see the dates where umbrella organization for all rare diseases were established, and you can see that all European countries have been able to reach this level of maturity. And not only at national level, but also at European level, North American level, large organizations were also established, like Eurordis, Nord, Code, and I will cite all of them, but you know, all over the world, there are patient organizations which are the voice of the patients, and but also the voice of the rare disease community in general. And this is invaluable. Next slide. So next, thank you. The direct impact for me of that situation with the patient organization in place is that we quickly had an orphan drug regulation in place in the US very early, like 1983, but and later in Europe, like 2000. But also national plans were adopted, at least in European countries. And the first one was the French one in 2004 that I was lucky enough to have conceived and written. So this was the first one, but when I look back, I think that we made some mistakes, and it's based on these mistakes that I will give you at the end some thoughts on how to do better than what we did in France. The second input was to, let's say, modify the way doctors were looking at their duties. And finally, now it's well admitted that, of course, the healthcare services should serve the needs of patients, adopting the views of patients, because sometimes the goals of the physicians of the healthcare system are not the ones that patients would think are the first ones to really provide benefit to them. So patient-centered research and development, patient-centered care were really new aspects of our activities, and this was induced by the patient organization. And as a consequence, patient representatives are now everywhere in all institutions, research institutions and hospitals, at a point where it's now difficult to find a patient representative to sit on in a committee because they are all already busy and involved in many activities, but this is excellent. So the impact on research was also enormous. The patient organizations often had to, let's say, raise money for the researchers, and they also were able to, let's say, have targeted grants for proposals, and this had a very positive effect on the networking between professionals, because the patients were requesting that the professional works together in cooperation, not in competition. And so the patients were really instrumental in changing the landscape. The patient also established many disease-specific registries, mostly national, some European or international, and these were very precious for the development of a better understanding of the diseases. So when we look at the landscape of registries currently existing in the world for rare diseases, there are about 1,000 of them of good quality, and half of them are run by academic institutions, a quarter by industry, and a quarter by patient organizations. So the patients have really played a major role. And at the end, we were able, thanks to the push from the patients, to establish this international rare disease research consortium, which was the first time that the NIH and the European Commission agreed to cooperate on something. You know that Europe and North America are competing most of the time, but on the topic of rare diseases, they accepted to work together, and this organization has established task forces targeting crucial issues in research and development, where the establishment of new facilities could be considered as pre-competitive and not competitive ones. So this is a major step. Next slide. So in addition to that, some areas like Europe went a step further and established a system, a mechanism to fund research efforts at a European level, providing a budget for cooperation between research groups, and also, let's say, funding infrastructures serving the research. And currently in this European Joint Programming for Rare Diseases, there are 35 participating countries with many beneficiaries. And so, I mean, it is for me incredible to see that, knowing that I remember when I started that we were just a few around the world, thinking that it would be possible to achieve that, but that the way to that was very, very long. So what are the direct impacts on research and development that we can cite? I would say that we had 3 steps. During 10 years, between 90 and 2000, the field of therapy development was active, but there were very few companies really interested at the beginning, because the market was small and that the return on investment was uncertain. So there was a large disinterest from investors, And only the patients were really convinced that it was possible and it should happen that drugs would be developed for their disease. But 10 years later, the climate was totally modified. There was a lot of enthusiastic claim from both regulators, from academics, from biotech companies, from pharma industry. Many biotechs were established or switched to the field of orphan drugs and rare diseases, and even big pharmas. If you look now at the landscape of who is developing drugs for rare diseases, all big pharmas are involved, and they are now leading the field. So in 10 years, we totally changed the landscape of R&D at world level. And if you look at the last decade, 2010-2020, and you look at the innovation happening in North America and in Europe, most innovative products are mostly for rare diseases. Not only we have succeeded to convince biotech industry and pharma industry to get interested, but finally we are leading the field of innovation in these sectors. And at a point where finally maybe the success is too big, too evident, and we are now facing a fear from the payers, seeing that many new products are on the market, and maybe they will not be able to pay for all of them. Next one. So the important, of course, event was also the dissemination of information. I think that Orphanet, of course, was an instrument in making this possible by providing a list of rare diseases. When you have to convince politicians or let's say head of big institutions that it is an issue, rare diseases are an issue, and that they should get interested in the field, you have to prove what you say. And by providing the list of rare diseases, the epidemiological data, an encyclopedia on these diseases, and the expert resources in 40 countries, plus a newsletter and report series. I mean, this gave, let's say, tools to be taken seriously by most politicians and by our colleagues, academic colleagues. And so I'm very pleased that this happened, because it was a lot of work to establish Orphanet and to populate this big database. But now I can see that what we thought would be possible is happening. But there is a part which is less known, which is the work which has been done to make the inventory of rare diseases and to assign a code to each of these rare diseases. Because nowadays, if a disease has no specific code, it is invisible in health information systems, and so in health records. And so at world level, there is this international classification of disease, which is maintained by WHO, and there is a new edition every 10, 15, 20 years. So the challenge was really to convince WHO to embark with rare diseases, because the last edition, which was issued in '94, included only 400 rare diseases. So now there is an 11th revision, which has been adopted 2 years ago, which now includes 4,500 rare diseases. So this is a big change, but not the adoption of this new edition is not yet in place. So this is an area where you have to, believe me, it is crucial that you lobby at your country level to have it adopted to code rare diseases in the healthcare system, because without that, these rare diseases will remain invisible. So what we did also was to push for the establishment of centers of expertise. So you are convinced, all of you, that it's very important to have the good expert in one place, because this will attract a lot of patients, and these patients will provide the experience on which to base the development of clinical guidelines and do good research. So it's a concentration of competence, of experience, of specific human resources, and appropriate organization serving the patients appropriately. But it's also a place where, of course, expert care, tele-expertise can develop, and where registries usually are placed. So this is a fantastic achievement, but also with limits that I will discuss further later. Next slide. And these centers of expertise, which, the previous one. These centers of expertise have been also networked, at least in Europe, for care through the networks of centers of expertise. And we have developed a typology of rare diseases, which that you can see on the screen, and to ensure that these networks would include all the centers in a given medical area. And this is certainly the best thing that we have done, working at European Commission level and WHO level, because in fact, it makes sense to put the centers of expertise in the current healthcare system, which is organized by medical specialty. It seems obvious, maybe for you, because dermatology is a quite distinctive specialty. But for many diseases, it's not that simple to assign them to a medical specialty. But believe me, it's very important to do that. Next slide. So these networks were also very helpful. But there is another area that I want you to be aware of, is that thanks to the technological developments, now we can have clinical decision support systems. So this support mainly the diagnosis of diseases, because there is a big issue with the delay between the first expression of the symptoms and the exact diagnosis for many, many patients. So currently there are now plenty of systems which are available to support the diagnosis by physicians, non-expert physicians or expert physicians. Half of them on the left, you see the ones who provide the support to make the diagnosis of diseases, including all diseases, the common ones with the rare ones. So this is more for non-expert doctors, because of course when they have a patient they cannot diagnose, they don't know whether it's a common disease or a rare disease. And there are also a long list of expert services for more expert people, people in tertiary centers, in centers of expertise, or at least in academic institutions dealing with rare diseases. And so this is also a major achievement, because it's impossible for a single physician to remember all the possible diseases, but now there are systems to help them. In terms of achievement, where are we with the therapies? We have, these are the quotes in Europe. We have many authorized orphan medicinal products, almost 200 currently for rare diseases. So it is a major achievement knowing the work which is behind each of these developments. Of course, for the patients is too few, and not that many rare diseases can say that some products have been developed for them. the diseases which are now covered by a specific medicinal products can represent roughly 10% of all rare diseases. So the way ahead of us is still long, but at least we have the system to incentivize this field. So the problem is that currently these products are on the market, but at a cost, at a price, which is just not acceptable. It's far too high. You see here a plot of the cost of each treatment, and you see the evolution with time between 1970 to now, 2020, and you see that some products are at extraordinary level of price, and this is very worrying because you can say that, of course, some of these products are extremely difficult to develop and to, let's say, produce at a large scale, but nothing explain totally the increase of price, which is constant, and even in the same category type of products. So it seems like the industry is a bit cynical and has understood that it's possible to make a lot of money with rare diseases because of the unmet needs, which oblige the payers to pay. So this is really worrying. And there is another worry. Another worry is that the most governments are trying to cut the healthcare expenditure growth when exactly at the same time the number of very promising molecules is increasing. So we can see on the right that the pharmaceutical expenditure is not growing, but the health expenditure is growing in all developed countries. And so because of this rise in the health expenditure, less and less products coming on the market will find a way to be reimbursed by the healthcare systems. Also, the sustainability of innovation is not guaranteed at all because of that. And so I'm not going to comment that in detail. It's too complicated and we have not so much time. But you will have to think in terms of what are the funding models for the future, because I don't think that the current models are going to work very long. So probably in the future we will have to develop financial agreements and health outcome-based agreements because the countries and the governments, the health insurers will not accept any longer to pay for these new products. I see four major big challenges. We have innovative technologies, and this is marvelous. We see now that advanced therapy medicinal products are blooming. Gene therapy is now a reality. We have somatic cell therapy. We have tissue engineered product, and especially in your field. But when we look at the figures, these products are developed, as I said, but most patients cannot access these products which are on the market but not accessible. Genomics also is developing very quickly, and especially sequencing technologies are a big hope for the diagnosis. And we have CRISPR-Cas9 also to engineer new therapies. But I see that this is challenging the clinical approach to diseases, and that the new generation of physicians are, let's say, not considering any longer the patient in its globality, and they do not approach clinically the disease and the patient needs. So this is also a big challenge that you should be aware of. We have very much digitized data, which has produced a very good thing that includes this universal language thanks to the code, because if you code signs, symptoms, results of investigations and the diagnosis with a universal code, it can be understood in India, in Guatemala, in China, the same way. So this is solving a bit of the Babel Tower. We have electronic health records, so we can access more information which is already recorded in a format which is understandable by computers. But this is also provoking a lot of fear, like the threat on privacy, which is quite worrying, but also a threat for the healthcare professionals and the researchers. They are now scary that what they produce in their research activity is not protected anymore, and that their IP is not respected enough. The performance of computers also is impressive now. So we can store a lot of data at low cost. We have a high computing power for artificial intelligence. It's easier to access data. But there is a specific challenge for rare diseases, is that we cannot access big data. We can only access small data. So there is a need for producing enough data to be in the race and to provide data for the development of new algorithm supporting care management and research. Among the new opportunities, I want to develop one, which is the open science trend. Next slide. What is the open science trend? Is that there is a new policy around the world, which is in place in the US, is in place in Europe, which says that science is producing many data, which are in fact pre-competitive, which should be accessible by everyone. These data should respect standards to be, so these FAIR principles are now an obligation for researchers, and this is excellent. But there is a big gap between these excellent goals and the level of organization in most institutions. So there is a need to support the upgrade of the organization of the data at the hospital level, at the research institution level, to ensure that these 4 principles are respected and are really in place. So these big disease data cohorts, which are possible because of all this development, will transform really patient care. And so we will certainly increase our knowledge on relevant phenotypes, on very specific phenotypes, very rare ones. We will standardize disease definition and outcomes. We will have tools to predict clinical outcomes and to optimize decision-making processes. We will be able to do patient stratification for clinical trials and to help and support better drug development. So I'm not saying that this is not good. I think this is a dream, and I'm very sad to be too old to see all these developments. It is exactly what I dreamed to see happening when I started, and it's happening only now. But you have to think about what are the side effects of all these developments. Next, so there are also new opportunities in the field of artificial intelligence. Next. So, but this, as I said, there are really problems for rare diseases. The primary source are not that many. On the disease, you have the omics data produced by a lot of hospitals and research organizations, but most of these organizations do not let their own data to be accessible by external users. We have now imaging data, and this is a new challenge because it is not that simple to code for to make this data usable by other groups. We have clinical data from the electronic health record, and we are able to serve the approach by deep phenotyping and to do unsupervised methods of development of new tools. But we have also big challenges in this area because of the need for harmonization of heterogeneous data between countries, between centers, between hospitals. Most hospitals have developed with tools which are dissimilar from the tools chosen by another hospital or center. So, I mean, it will take years before we agreed on data standards. Industry and in physics, in astronomy, they have done that many years ago, but in medicine, we are only starting now. So this is a new challenge. So my concluding thoughts are the following. I hope that you will be the ambassadors of open science principles. I said that there are a lot of obstacles and that the way forward is a long one, but it's really such a good principle that you should support it. All the data collection should be opened for reuse, for collaboration, and you have to push institutions to support that trend and also to support their data infrastructures, because the doctors, the researchers at their level, they cannot afford for having secure systems, the right infrastructure in place to be able to make their collection of data accessible, protected, safely, and this requires a lot of funding. So you should also work on common data elements, ontologies, metadata, lobby for common standards between institutions to store and analyze images, let's say genomics data and so on. So, and all these institutions should now switch to open source tools. So you have to think globally but act locally as usual, which means that there is no now need for centralized database at world level. Which is much better is to ensure that each institution producing data, hosting data, is well organized and can cooperate and exchange that with others. So this is a total change compared to the way we were thinking some years ago. Next, so what matters is the ecosystem. And I think that in the rare disease field, we are quite mature. We have really a system. We have now a community of rare disease patient organization, of rare disease centers of expertise. We have computational tools. These are the general ones. We have data sets, very precious data sets. So we can have an ecosystem. So it's just a matter of organizing it properly. So you have also to contribute to solve problems in conflicting areas. So there are a few conflicting areas. I mentioned the way the problem of the too high prices for therapies. So I think that we should think with industry about new economic models for public-private partnership, and we should ask them to accept that there is a transparent approach to the construction of the prices, but also that the rules for the research and development are not modified too often, because a very stable environment is very important for industry. And we have still to fight for patient-centered health services, because the diagnostic delay will not be solved by genomics, the genomics approach. It's still depends on the training of the doctors, on them having enough time to see the patients and care for them, and they should spend time with the patients and not too much with their computer. Next slide. So this is a matter of organization. So you have also to contribute to appropriate services. As I said, centers of expertise are excellent, but they are to be embedded in the healthcare system. So personally, I think that the point where France did not do well in the past is to have two specialized centers of expertise by too few diseases, when we should lobby for having rare disease division within a normal hospital system. So expert centers for rare dermatological disease, rare eye disease, rare pneumological disease, and so on. So this should be embedded in the medical activity to ensure that it is sustainable on the long run. We should also promote the use of clinical decision support system and adapt the existing ones to all national languages. And also my last idea will be about the clear separation between care and research. What I observe is that currently there is a lot of confusion where, because of the interest of research in the area of rare diseases, sometimes the patients do not know whether the services are standard services already validated with a quality control and so on, or if these are just new approaches which are not yet validated. And I think this is a mistake again. So we should have excellent departments doing a lot of research in the research framework, and then have also care about having also clinical centers which are just respecting clinical guidelines, working properly and accessing good labs, performing tests which are already validated. Next slide. So thank you for your attention. So I have touched a lot of problems and solutions, and I hope that it is of interest to you, and that you will find your own way in this field where you are an example for other medical specialty, because you are especially well organized. Thank you.
Hi, thank you so much, Dr. Aymé, for your wonderful presentation. I know that I learned a lot, and your points around ensuring that we continue this collaboration between patient advocates and medical professionals to improve access for rare disease patients for treatments is incredibly important.
I would like, first of all, to thank Professor Aymé Ségolène for your inspiring talk, which really addresses a lot of areas and also a lot of challenges. And so you have told us that now we have a very good starting point and already a number of essential tools available to continue the work. But on the other side, you have also underlined how governments are trying to cut the healthcare expenditure.
Yeah.
Now, how can patients' organizations try to make aware the politicians about the importance that we have unmet needs, we have expectation, that we have do you have some suggestion as how we can physicians and patients organization work better together to be stronger voice, to change this trend?
Let's say the major problem is the cost of new therapies. So it's what is really frightening the payers, the health insurers. It's and honestly, you know, I have many friends working in big companies. You know, I know that they are good, they are dedicated, but honestly, currently the prices they request are just insane and does not correspond to a good, honest return on investment. I mean, they should make benefits. That's normal. They have taken big risk, and of course they should have a return on investment, a big one. But you know, I think that cutting by 50% or even more the prices, they would still be very wealthy. So they just try to ask for the maximum and see when it's going to be unacceptable, you know, by payers, and they are just trying. So I think that the governments, the physicians, the patients have to be very vocal and say, we will not accept that, you know, explain us why your price has been set at that level. And they refuse, of course, to answer this type of questions, but it's possible to impose the transparency on prices, not by a very precise one, but by big categories of let's say, reasons for having high cost, the size of the market, whether it's a biotech product, which is extremely difficult to manage and to commercialize, whether, you know, they have spent 30 years of development or 10 years. But usually the problem, I know why these prices are so high. It's because now the big pharmas and the big biotechs, they don't do the research by themselves. They let small biotech develop new products, take the big risk at the beginning, and when they are successful, they buy these biotechs. So they pay a very high price to buy this biotech, because of course there is a lot of competition among the investors. They are all looking for good investment in biotechnologies. So they pay a too high price at the beginning, and then after that, as they have invested, you know, they have to ask for enormous prices to have their own benefit. So it's a vicious circle, because they don't want to take any risk themselves, but they just rely on the risk taken by small biotechs, which are in fact funded by public funds. Because if you see what the US are investing to support innovation in biotechnology, where you look what Europe is investing in this field, you look with COVID-19, I mean, all the research has been paid by public funding. And then suddenly, you know, there is a biotech which can develop a product which has been basically developed by public funding, with a small part which is, let's say, funding from investors taking a big risk. That's for sure. So it's all the system which is too unsecure currently to be sustainable at the end. So it's why I think that the trend, the right approach would be to have arrangements between the private sector and the public sector to share the cost of development, and then to share the benefits at the end, because we cannot go forward like that. And when it was just rare diseases, the diseases just of the children, and the big politicians were, let's say, not that sensible to the field. But now that it's true also for cancers, for some major, more common diseases, you know, everybody is afraid, because they see that most products will not be accessible. So in the USA, it's still accepted. I don't know why, because for us in Europe, from Europe, you know, our point of view is that if there is a product, it should be accessible to everyone. So we have to find solutions. But honestly, we cannot go very long like that. Gene therapy is now a reality. Gene therapy, you cannot assign a price the same way as you did for common drugs. I mean, it's a one shot or a few shot administration, and so it's the price, upfront price, is extremely high. So for a hospital, for a town, a region, a country, a small country, it's just not affordable. It's not affordable. But this could very well be imagined as a development in common with the let's say academic hospitals and the research institutions, where the improvement of the techniques, where the management of the patients would be taken by the institutions, and where, you know, the industry would be a partner only for their capacity to industrialize better, to have in place quality controls. There are many things they do much better than the academic sector. But each of us, we should offer what we have as the best aspect of our activity. Because if we do not do that, I'm afraid that a lot of innovations will not be accessible at all in the future, at all. I'm sorry to be so negative, but for me, it's like it's breaking my heart, you know, to see that now we have so many innovations and we won't be able to provide them to patients.
Ségolène, may I ask you a last question? Then I'll let the other speak and ask. But to understand well, do you think that the patients' organization should become more politically active and more politically loud? Because we hear every day, you know, climate change, reduction of carbon dioxide emission, protection of wild animals in Africa, not use. Should not patients' organization more? We have right to get the drugs. We have right to have access to price, to drugs with reasonable price. What should not be a stronger voice of patients' organization?
I think you have an opportunity also with the pandemic, because the discussion on whether this is a common good or not, and the vaccines are a common good, is exactly the same topic as the one I'm developing for rare diseases. So it's now on the table, you know. How should we work between the academic sector, the public sector, and the companies, knowing that we need the companies because they have a know-how which is extraordinary, but they also need us because they don't do research anymore. So, you know, we should find an arrangement. So it's exactly what you said. The world is changing very rapidly, and I tell you, the current economic system will not last very long in the field of healthcare, because we are really at the limit, and most countries are really reaching the limit of they cannot increase more their expenditure any longer. So I mean, there is no choice but to be around the table. So if you meet industry people at your level, if you meet your politicians, if you meet your head of institutions, I mean, you have to express your worry and say, no, we cannot accept that. But I don't think, honestly, you told me that have been useful to the community in the past. I can tell you my secret. My secret is that I never go and see anyone with problems. I always go and see people with solutions. So I always go and present possible actions for them, possible transformation of what they are doing, small ones, big ones, just because we are the experts. You know better, what your patients need. You know better what your fellow patients need. So you have to express, of course, the fact that you exist and that you should be considered, but also that there are possible solutions to your problems. So you have done that beautifully because you have networked, which is very difficult, it's time consuming to network. It's resource consuming. I mean, so you have done all this big effort. So you have built the community. When I said, the community has to be in place, the ecosystem has to be in place. Your ecosystem is in place now. So you have a lot of strengths, but you have now to imagine the solutions at the healthcare system level. And unfortunately, it's very dependent on the healthcare system. So I know that there are people from several countries today in this webinar. I mean, each country has a different organization, so the solutions cannot be the same everywhere. But at least you should imagine at your country level, at your regional level, what can be done by just a transformation of the partnership with the responsibilities. I'm sure there are solutions. They are never ideal, never total, but we can improve the situations. And I hope you will have ideas. You will have enough imagination to find solutions.
Thank you so much, Dr. Ségolène, for these wonderful comments. It's very much appreciated for you to be sharing your knowledge with us.
Well, we're fortunate. We have amazing patient leaders in our umbrella organization. So they will all, I'm sure, do everything they can for their patients. So I think this is probably a great place to conclude. We've gone over time, and we're so grateful that everyone stayed on for so long. And obviously, especially our speakers and presenters. So Nicole, I'll pass it to you to just close the event.
Thank you so much, Dr. Ségolène, Lucas, Mana, Jennifer, all for your support in this webinar.
Thank you, Dr. Aymé. Thank you, Luke.